The revenue cycle and staffing models will change significantly under HHGM. The impact from switching to the 60-day, which is under the current HHRG model, to the 2 30-day episodes under the HHGM model will lead to an increase in the number of claims that the biller will need to follow up on. Under the 60-day model, we submitted 1 RAP and 1 final claim to Medicare. Under the HHGM model, there's a potential to be submitting 2 RAPs and 2 final claims. This will lead to a need for increased staffing, and we'll need to reevaluate the number of Medicare dollars that each biller and collector can follow up on. The other area that would also be impacted is cash posting. Due to the number of adjustments, both revenue and system adjustments that'll need to take place, cash posting may also be an area that may need increased staffing or reevaluation of the type of cash poster that it is. It may require somebody with a little bit higher level analytics or accounting background to calculate those system and revenue adjustments properly. Comparing the current HHRG model to the HHGM model, there'll be some revenue and system adjustments that will remain the same, such as provider overlaps, PEPs, partial episode payments. Under the HHGM model, an early episode is considered as the first 30 days. All other subsequent episodes afterwards are considered lates. Some of the items that are going to differ under HHGM will be LUPAs. It'll no longer be classified as 4 visits or fewer. Under the HHGM model, a LUPA can range anywhere from 2 to 7 visits, which will require additional review and revenue adjustments within the EMR. Another area that is also going to be impacted is there'll no longer be therapy adjustments as they currently exist for revenue under the current HHRG model.
Each home health episode is actually classified into 2 distinct admission source groups. And those groups are either community or institutional. And that's basically how providers will be reimbursed by Medicare based on understanding where those patients derived when they entered home care for services. It's critical that home care providers really look at their intake staff, the front end staff. The staff will need to be extremely diligent in seeking that information. Initially, most home care providers may ask a patient, where did you receive services 14 days ago? Typically, a patient can't remember that information, or it could be incorrect information. Again, this will impact the provider's reimbursement. So the intake staff needs to be a bit more diligent in going back to the referral source and finding that information out and ensuring that the information is correct. Because if a patient came in to a home care provider straight from an acute care setting, hospital, then in the eyes of Medicare, they're going to require more services. But if they came from an outpatient rehab facility or another home care facility and they're transitioning to a new home care facility, they may not need as many services. And again, not needing as many services will impact the overall reimbursement of that provider. So the intake staff needs to be extremely diligent, and knowing where that patient came from, whether it's from the community or an institutional setting, will be critical.